Welcome, welcome. It's nice to see you all. Really appreciate your coming to share the next 45 minutes or so with us, talking about Back to the Future, Forces Driving Care to the Home. My name is Mike Cantor. I'm the Chief Medical Officer for CareCentrix, and we're going to have the panel introduce themselves in just a minute. What we're really here to talk about is how do we actually facilitate, enhance, accelerate the process of bringing care to the patients rather than bringing the patients to the care. And we have a really esteemed panel that's going to share some interesting insights with us, and we're going to have plenty of time, I hope, for questions and answers from the audience. We want to make sure that questions you have are being addressed and answered, and so we look forward to having an interactive afternoon session. If I learn how to use this properly. There we go. So here's the agenda. We're going to introduce the panelists. We'll have them introduce themselves, actually. Then I'll share with you a little bit of the information that we have about key issues in home health. We're going to hear from the panelists in terms of their questions and answers, and then, again, we'll throw it open to you. So it should be, like I said, a very helpful, interactive session. So by way of introduction, I'm Mike Cantor, Chief Medical Officer for CareCentrix. I'm a geriatrician and a lawyer by background. I've been fortunate enough in my previous life to have made house calls and worked in home-based primary care programs, and I'm really excited to be with you this afternoon to talk about home health and how we actually take better advantage of this really helpful, important resource. Bruce.
Good afternoon. I'm Bruce Greenstein. I'm the Chief Strategy and Innovation Officer at LHC Group, one of the largest home health companies in the country. And we do other matters in post-acute care and data sciences as well. About half of my life has been in the private sector and half in the public sector, so I'm also a recovering regulator, most recently at HHS as the Chief Technology Officer.
Hi, I'm Greer, and thank you for making the trek all the way down here to our session this afternoon. We appreciate it. I'm the president of Turnkey Health, a company that manages health plans members who are suffering from a serious or advanced illness, focusing on community-based palliative care. My background is a little bit different than Bruce's. My background has always been in the healthcare space, healthcare technology, and Medicare Advantage and commercial plans.
Hi, my name is Anita Pramoda. I am an engineer by training, and I continue to code. Our company-owned outcomes, we predict events. We try to understand what are the drivers of those events, filter out which ones of them are addressable, and then based on that, we partner with customers to make them actionable. So that's my world. Thank you for having me.
Good afternoon. My name is Sherl Brand. I am a registered nurse. I'm a senior vice president with CareCentrix. My career has been a little bit eclectic, has always been in the home care space, but I am actually a visiting nurse. So I have gone into homes and rendered care from one extreme to the other, custodial to individuals on ventilators. I'm excited to be here and to talk about this topic because I'm certainly very passionate about it. So thank you.
Great, thanks everybody. Let me share with the audience. Actually, before we get to work, we wanted to put you to work. And so we're going to ask you an interactive question. We're going to show you in just a minute the responses. So what you need to do is, if you have a smartphone, and some of you probably do, you can use that and text CareCentrix 392. That's what you would put in the body of your text. And the address you would text it to is 22333. So 22333, and then the body says CareCentrix 392, and then you'll be able to answer this question. The question is, the amount of home health care currently provided is A, too much, B, about right, or C, too little. So again, text CareCentrix 392 to 22333. Panelists, feel free to jump in if that's something you feel like you have to do. So Bruce is on it. And we'll give a few seconds for this to come through. This is normally the joke-telling portion of our program, but not a good idea, so we're going to skip that. Wow. I think more than one person has answered, too. That's the really good news in terms of... We'll give another few seconds. It's great to see diversity in this audience, at least diversity of opinion. There we go. All right, so we're starting to see some more answers. Okay, another 10 seconds or so. And all these results are anonymous, by the way. There's no way for us to track back to your cell phone, text number, or anything like that. So feel free to text for another second or two. Everybody's good, I hope. All right, so what we see is about 90% of people think not enough. A few people say about right, and about 10%, a little bit less than that, say too much. So it's an interesting question, right, in terms of are we providing too much, too little, or about the right amount? And it's sort of a trick question in a way, right? Because what is home health? It turns out there are different definitions if you think about it from the perspective of ways that home health care has traditionally been covered or paid for in the US. So under Medicare, home health is traditionally offered as part of a skilled episode, which means the patient has to have a certain level of illness, and the patient has to be homebound, and that's a whole other session's worth of discussion, I think, which we will not get into this afternoon, or maybe we'll a little bit. And if they meet those criteria, then the patient can get a combination of services, home health nursing, the therapies, physical, occupational, speech and language pathology. They get limited amount of home health aides, depending on the agency, that varies quite significantly, social work visits, and durable medical equipment. So in the context of that skilled visit, durable medical equipment, by the way, can be outside of a skilled context as well, but that's generally part of someone comes home from the hospital, they had surgery, they need wound care, they need bandages, that kind of thing can be covered. Recently, Medicare has begun to change, however. So what we see is that Medicare has begun covering some new things. Because it's a relatively recent change in the last couple of years, there has not been as much uptake of these newer offerings as there has been for the more traditional Medicare. So remote patient monitoring, putting a blood pressure cuff and a scale in someone's home with a device that connects it to the internet and feed it back to someone, house calls by physicians or practitioners, physician's assistants within the context of like a home-based primary care program, chronic care management, so paying for more longitudinal services, chronic activities of daily living support. These are things that are potentially covered under what they call supplemental benefits, which are what Medicare Advantage plans can offer, not under the Medicare fee-for-service program. These kinds of things become available. Video visits are now paid for under traditional Medicare. Not many people are actually using them yet. And home infusion is something that under certain like Medicare Advantage plans may be covered, but under traditional Medicare, not so much. That will be covered, I think, starting in 2021. I'm not sure why Congress decided to wait 3 years between passing the law and actually getting the stuff to the home, but they did. So it's starting and things are moving in the right direction. There are things that are evolving, again, because of the supplemental benefits being enabling health plans with Medicare Advantage offerings to actually cover things differently for different people based on their needs. So they don't have to universally cover everybody. And it does not have to really improve patients' health. It can maintain the health or prevent decline. And so we see homemaker support as one option, in-home respite care for people who have dementia, for example, meals, home modification, palliative care. These are services that are going to be offered by health plans at their discretion. Maybe some are doing it now, some are doing more in 2020, and we anticipate that as time goes on, we'll see more of this. Palliative care is a really good example. There's a special program called VBID, which is the Value-Based Insurance Design Program under the Centers for Medicare and Medicaid Innovation. Starting in 2021, health plans will be able to offer hospice benefits as part of that Medicare Advantage suite of benefits, which is different than what's traditionally been covered. So there's all this opportunity for innovation, and it's starting to happen. Not quite clear yet how many plans and whether any or some of these will end up as part of the traditional fee-for-service Medicare beneficiaries, who still make up the significant majority, 60 to 65% of Medicare beneficiaries are not in Medicare Advantage plans today. So data show that home health makes a very positive difference. And there are two studies on this slide. The top panel shows you a large retrospective cohort study where they compared patients who were admitted to skilled nursing facility versus patients who were admitted to home health services or got home health services after discharge. What they showed was the patients with home health actually had a slightly higher readmission rate, 5.5% higher or so, but the total cost of care for that episode from a post-acute perspective was lower. And the 60-day Medicare cost was $4,500 lower. So even including the slightly higher readmissions, it's still less expensive, and no difference in mortality. So it wasn't like people were sent home and a bunch of them started dying. That's not what happened in this retrospective review. It really points out that we may be underutilizing home health and taking advantage of it in order to provide better care for our patients. The separate study, actually, from Cleveland Clinic found that, actually from Case Western, showed that home health utilization really had an impact long after the immediate post-discharge period. So they found significantly lower costs of care and mortality for those patients that got home health within 1 year for those patients who got home health after discharge. If you look out a year ahead, they actually do better. So this seems to be consistent in terms of more home health seems to be better in terms of offering patients less readmission risk and less total cost of care. These are data from Anita, so thank you, Anita, for sharing this with us. What this map shows you is the United States. In each of these circles, and my laser pointer can actually reach all the way over there. So these circles, the size of the circle is correlated with the cost of the episode, and the color is associated with the home health agency, basically how long it took them to get into the home. So the darker the pink color, or the more purple it is, the longer it took for the home health agency to actually send their person into the home. And what you see is a correlation between size and color. So the longer the delay, the higher the cost. And that's a pretty consistent correlation. This population were 75 to 79-year-old women, men who actually think I had female patients, who were after joint replacement. So basically, if you delayed getting a nurse in the home, you could expect to have higher total costs of care for those patients. Similarly, she looked at women 75 to 79, the relationship between responsiveness, how quickly the home health services arrived, and readmission rate, and found, guess what? Same kind of thing, the darker the color. In this example, Washington State, they have a higher readmission rate, and they have a longer time between when the patient was discharged home and when the services were being provided in the home. So clearly, home health services, not only do they need to be provided maybe to more people, but if you're going to do that, you want to make sure you get them into the home as quickly as possible. That reduces risk of readmission and total costs. So, enough from me, on to our exciting panelists. We have 2 questions for them. We're going to begin by asking them the question you see here. So given the positive impact of using home health care for post-acute care patients, what are the barriers? The studies I showed you are relatively recent, but we kind of get the idea that if people go home with help, they're probably going to do better. So we're just going to ask the panelists to answer this question of what are those key barriers from your perspective, and we'll come back in a minute and talk more about some solutions. So Bruce, tell us about the barriers.
So I'm going to talk about 3 different areas. One is around silos, and those silos, we'll talk in the context of MA to start with. With the data that you showed, and none of it is counterintuitive, you would expect that quicker care to home, more home care leads to overall cost of care reduction. Yet, decisions are being made across the country today that recognize home health as a disparate bucket, and SNF would be another bucket, and other parts of the total spending, the MLR, will be separate from home health. And so what we see is these concurrent managing of spends rather than thinking about it all together. And that's clear in the MA world. Even the most sophisticated MA plans still don't have, I'll just call it an enlightened view, despite the fact we're being video recorded, and somebody might show this again.
Excuse me, Bruce.
I love all those
Excuse me a
guys.
second. So how many of you work for health plans? Uh-oh.
All right, so you guys could talk to me afterwards and help me understand where the enlightenment is. I'd like to see the light and work with you more. But we're seeing these decisions being made separately. Now, it's also the same case in the evidence in the ACO world, where we see about the same amount of reduction in spend in home health as we do in SNF for post-acute, which means that we're not looking at ways for zero-sum or substitutability to use and drive more patients that are clinically appropriate to lower cost settings and manage the total cost of care. So that's the silo piece. And I think a lot of it has to do with organizational culture and the way we make decisions and who's the medical director as a hospitalist and also medical director in the SNF. There's a lot of pieces going on. There's also family cultural values to go to something that's that provides more wraparound care, let's say in a SNF, than in the home with clinical care. The next piece is around financial alignment. And again, there's often not a reward to be had for lowering the total cost of care. So it's very similar to the first, the silos. But in this case, whether it's in the SNF whether it's an ACOs making a decision between SNF and home health, those total cost of care comes up quite dramatically. We run one of the largest ACO management companies in the country, and we do analytics on this question all the time. We found using the frailty model, was published a few years ago by a group out of Harvard, and we looked at our population, 460,000 members, and we saw 34% have identical clinical attributes that go into the SNF as go into the home. So we know that's at least a third of SNF. Those that are destined to the SNF, we can move to the home. And we also work with other researchers that cite it's closer to 50% what they say. And then additionally, the recognition in some of the work that you've done that about half of all readmissions happen to those that never get any post-acute care at all. So we may be penny wise, pound foolish, or just unaware or unenlightened about ways to treat our post-acute care period in the most clinically appropriate and cost-effective way. And the last piece is we're not really set up to think about using the home as the proper tool. We think about it like your chart in the first column, where we think about it as a Medicare-defined benefit, not really a set of healthcare services that take place in the home. And that's why when we think about some of the more interesting innovations that we've seen around the country that happen in the home, it's by companies that have figured out how to trick the system in a good way, usually by contracting with MA plans. So you think about Aspire, CareMore, Landmark, some of the hospital at home programs that are still in their infancy. They don't fit in the world of Medicare properly, so they have to go around the system to make up new rules and come up with a new payment mechanism, and that's often one of the most innovative, disruptive factors. It's not that they're using space-age technology and robots in the home and hologram clinical personnel into the home. They've figured out instead how to pay for the service that is tried and true and works and ends up saving money in the long run. So those are the three barriers that I see up front.
Thank you.
That's a perfect segue into, I guess my first comment would be the reason why it's so difficult to gain adoption is because we're trying to build a solution around a problem that was established and viewed incorrectly a long time ago by Medicare, and we're still living through that today. As Dr. Cantor pointed out, there's a lot of innovation going on around, and I'll give you my perspective because it's home-based and community-based palliative care, around that within Medicare Advantage and Medicare supplemental benefits. But when you think about the skilled environment that we have out in the home, and you have a defined home health benefit, you have a defined hospice benefit, and then you have all these patients who could benefit outside of that environment in between. So instead of thinking about it as post-acute care, almost think about it as pre-acute care, things that we could do in advance of that care. And as I think as the models have evolved in home health and in home engagement is probably a better phrase even to use than home health, that it's created an availability issue. Because the availability out in the community, first of all, you don't have the mechanism to affect or contract with those entities. And the companies that Bruce mentioned, similar to ours, at least on the Aspire side and community-based palliative care, he's absolutely correct. You have to trick the system to be able to get the right care at the right time for the right member in that health plan. And that's a big, big deal. The other issue that you have that we see a lot of is availability. So there's clearly an availability issue on the palliative care side. If you think about the world of palliative care as you've got to get a physician, you've got to get a nurse practitioner, or you've got to get a PA in a patient's home, you're going to have a very, very difficult time getting that done. But if you think about it differently, in that you can use nurses and social workers who are doing all of the heavy lifting in the hospice environment, if you can repurpose those staff to provide palliative care out in the community, out in the home, it makes a huge difference for the member and for the caregiver. So not just focusing on the member, and that's another thing that we typically, because we inherited the system through CMS, there hasn't been a lot of consideration for the caregiver. That portion itself drives a lot of utilization and negative outcomes. You know, when we think about, or through our lens of palliative care, we're thinking about advanced illness, last 6 to 12 months of life before hospice. We're thinking about serious illness, which could be temporal. and all bringing it back to how do you get the resources at the right place at the right time to the member out in the community. So I think the challenge has really been established by Medicare and some misperceptions around home health, but trying to put everything in a box. I mean, you referenced silos and trying to manage specific silos. You manage down one silo and it's whack-a-mole, right? Because it's popping up somewhere else. If you treat a condition like end of life more holistically, you can eliminate the whack-a-mole principle and the total cost of care drops. And we've seen it time and again, have studied it ourselves. So I think that is the core issue, is that everybody has to start thinking differently about how to engage with members and their caregivers out in the community.
My view is that of a technologist, so I often think about issues that are addressable by technology, right? Not everything, technology is wonderful and powerful, but not everything can be addressed with technology. So I think about barriers in 3 vectors. One is what I call a logistical vector. So if I were a patient, I probably don't want home health because I'm not sure if I will get my questions answered in the home, right? Or will someone get to me, the very specific specialist that I need help from, will they get to me? Will they get to me on time? And will I get the right kind of care at home? So there's a whole bunch of logistical issues there. The second vector that I think about is an informational vector. And what I mean by that is, if I were a patient and if I'm home and my situation is very complex, who will answer my questions, right? I feel very vulnerable. There's an information asymmetry between me and the clinician that takes care of me. And when I feel vulnerable, I want answers to my questions, I want assurance, I want compassion, I want competence, and I'm not sure whether I will get it in that home setting. And the flip side of information is also a problem from a clinician's perspective. We are creating information or knowledge, medical knowledge, at a rather dizzying pace. The pace at which we create is well past our ability to cognitively ingest the knowledge we're creating. So our clinicians are drowning under the weight of the knowledge we're creating, and so then that presents a barrier as well in terms of can we deliver the right care to the right patient at the right time in the home setting. And to the extent we can do all of these pieces, then shared decision making is a pipe dream, right? Because the patients don't understand what's going on, and they certainly don't feel empowered to influence what it is that is happening to them, and can't help figure out whether that's in line with what it is they want. They don't know if it's going to get covered. They don't know if they'll get the right help. So there's any number of those barriers. And then the last one is thinking about it from a care pathway perspective, and that's including the totality of the patient. So patient as a human being is somebody that, because they have a chronic disease, they have a 7 times higher likelihood of being depressed. That's as much a part of their life as the CHF is, right? And that they don't have an air conditioning unit and it's 117 degrees in Las Vegas where I live means, asthma plus 117 degrees plus no air conditioning equals I'm better off at the ED, right? So it's the totality of the patient and what will they need beyond just the medical interventions to heal and thrive in the home and in the community.
So I'm also going to highlight 3 specific areas. One would be, from a barrier perspective, benefit, design, and/or limitations. So when we think about the level of services or the amount of services that can be provided in the home, certainly Medicare is looking at expansion via supplemental benefits, but it's still not enough to positively and directly impact positive outcomes in the home. Along those lines, we have a very apparent conflict. If you're a Medicaid beneficiary, federal regulation prohibits homebound requirement. Yet if you're a Medicare beneficiary, homebound requirement is in play. So if you're a Medicare beneficiary, we need to wait until you get to a point where you can no longer get out of the home in order for us to bring services in the home. To me, that defies logic. The second area I would highlight is workforce. There is a serious issue out there right now, and in particular in rural areas, but really it's prominent across the country. Home care today is still a 1-to-1 ratio. An individual, a nurse, a home health aide, a therapist will go into somebody's home, somebody's apartment, and render care to them. We have a real crisis on our hands with, nurses aging out and retiring, a demand based on the tsunami of aging and the fact that people are now living longer, people have chronic and complex needs, and they want to remain in their home. So we need to figure out how we get them the help that they need in their place of residence. And then the third area would be social determinants of health. I don't really like that term. I like to call it barriers or obstacles. So we get the help into the home. But if fundamental needs for those patients and their families are not being met, we can bring the best things in. We've got to really focus in on things like adequate housing, access to healthy food, the fact that many are living in social isolation. Those are critical elements to address, and certainly home health can weigh in and play into addressing some of those along the way.
Thank you, and thanks to the panel. I'm going to, in the interest of time, ask you to keep your responses to the next question really brief. So Sherl, start us off with telling us, so given the barriers we've identified really clearly, what are some key solutions in a very succinct and helpful way?
We should get rid of the homebound requirement. No doubt about it, that's number one. Number two is there should be a support for and payment and endorsement for use of technology in the home. So workforce shortage, if we have the ability to have video connections to patients in their home, nurses, therapists, they could address upcoming or arising needs, clinical needs for a patient often fairly quickly by either biometric devices or, again, video interaction. That would also be helpful from a social isolation perspective. And then social determinants of health, addressing those. The more home health connections that we can bring into the home, the more we can address things like social isolation, are they getting the right food? Home care agencies do understand and are aware of all of the community resources available in the communities that they serve. So helping to make those connections would be both an output from the delivery of home health services and would also remedy those challenges that patients are facing.
Great, thank you. Anita.
So 3 things. Logistically, if you have Amazon Prime, you can get shipment as quickly as 1 day for how many SKUs? A few billion SKUs, right? So that's queuing theory and supply chain excellence taken to its extreme, right? We should be able to apply those similar principles and be very efficient in how we route our resources and people to address some of the issues that you described, Sherl, in terms of getting the right clinician, the right equipment, the right supplies, whatever it is that we need, and get it to them on a timely and efficient basis. There's an opportunity to apply known principles from other disciplines into healthcare. In terms of information, I do think the greatest opportunity is in summarization and simplification, right? So if you're a sick patient, yes or no, that you feel woozy in your head, not so confident, feel vulnerable. Yes or no, brief answers, simple answers, very quick answers, and in a super summarized form so that someone can ingest it. And similarly to the clinician as well, the death by EMR, right? Which is, whereas in the past it was like I had to flip through pages, now it's death by clicks and drop downs. And if you can summarize what matters to them very quickly, then I think that's a huge opportunity in there, so that then they can act on that information. And I think that processing and summarization is a job better done by silicon as opposed to human beings, and I see some opportunity there. And then on the third one, which is when I think about care planning, that vector, I think about it as having computational support for our decisions. So sometimes there's social stigma associated with a barrier someone experiences. Sometimes there is sometimes there is not access to certain social services like non-clinical services that they need. And these are all relatively easy to discover. If we thought about our information and knowledge sources as something beyond just clinical, if we thought about it as air quality information, if we thought about it as temperature and weather data, if we thought about it as credit card data, if we thought about using all of these different pieces of information which all govern certain facets of people's lives, then we have a better informed view, and then we will be better able to prioritize what it is that person's highest level, unmet need is and get it to them.
Thank you. Greer.
I think on a very basic level, the solution to the problem or overcoming the barrier sits within this room. I mean, based on the show of hands earlier, for those that are representing a health plan, Medicare tends to dabble in Medicare Advantage before they take a leap, and they're doing more and more with CMMI, and they have all kinds of interesting initiatives going on. But from a leadership perspective, I think the key is overcoming the thoughts and the silos that exist now, and really thinking about other strategies to better engage with members and their caregivers out in the community and out in the home that may be leveraged to better benefit for total cost of care and total quality of care.
Thank you.
I'll answer it by just thinking about what the problem is. In this room, we're trying to manage trend. And if we're trying to think about what the budget is for post-acute care, which we're trying to attack, we have to think about what does that really mean. So we know 90% of all post-acute care is just within home health and SNF. And that breaks down to about 61% goes to SNF, 39% goes into home health. So there are opportunities here. On top of that, as we mentioned earlier, 50% of readmissions are going through patients that don't have any post-acute care. So I like to make it very crisp and concrete. How do we contract better between those that provide care in the home and those that are contracting for it, the plans? So I think about it as a way I'd be happy to take a PMPM for all post-acute care in SNF and home health, and I'll run it out for 60 or 90 days, and I'll do that all day long. I'll also do it where we take a look at ways to incent or put more pressure for patients to enjoy the opportunity to go home instead of being in a SNF for a longer period of time. And on top of that, I'd take some upside on being able to shorten the length of stay in a SNF to be able to bring home patients where they ultimately want to have better chance of higher quality, better outcomes, and the food is always better at home than it is in a SNF. That was my one joke for the day. And if you think about it, if we try to manage it this way and even take the risk out, say, to 90 days or longer post-acute, then you can start to fold in some services that are not offered up front. So transportation, food, remote monitoring, personal care services, which we know study after study has shown that we can bring down total cost of care if we deploy those services. But the first question that I get is, why don't you do that now? If we don't get paid for it, we're not going to underwrite it ourselves because we think it's good and it's going to lead to lower cost of care for the payer, whether it's Medicare or an MA plan. But those opportunities are so ripe today. If you think about going across your entire portfolio in MA, about the largest spend of unmanaged care is in post-acute today. And the technique has been at commoditizing the service, finding if you think about the lowest cost, either in an auction model, you just pay whoever the lowest amount so that some home health will take the rate and then you stick it there, you're always going to get commodity services. So the opportunity to contract smart to get much better performance and lower total cost of care is there, and it's a very exciting time to do it. We're doing it in many parts of the country today. There are many home health companies that would like to engage in this, so it's not just one that you have to figure out how to scale, but there are plenty. And this doesn't stop at the MA water. We're going to make an announcement either later this week or early next week on Medicaid. So the idea of using post-acute care as a major lever to manage both the post-acute care total spend as well as the total cost of care is there.
Thank you, Bruce, and thanks to the panel for your answers. Really appreciate it. We have time for some audience questions. There's a microphone. Anybody have any questions? Everybody still awake? It is late in the afternoon. I had to check. Yes.
Right now, it doesn't seem like payers have very much insight into what's going on with the individual patient from the moment they're discharged from a hospital and admitted to a home health agency. Do you all see any ways that that's changing or what value that could create?
So just to be clear, so your question is, how do payers become more aware of the patient characteristics at the time of discharge so they can support the proper use of services?
And even throughout the 30 or 60-day episode so that they can tell if the patient's headed in the right direction or the wrong direction?
Yeah, we manage 90-day episodes, which is becoming more typical, bundles and so on, so you're right. Panelists, responses?
I say there's two things that I think about. First of all, you're right. Payers don't have much insight, and even the institutions, the health systems that are discharging the patients don't have much insight and really want it. So there's activity going on in Washington, D.C. for a post-acute care interoperability work group. It's got an acronym this long. It's called PACU, like the fighter, but it's to do just that. Our company is continually working with our home health EHR vendor to make connections to Epic and Cerner to start with. And there are many health systems that demand that their home health is on their version, let's say it's the same instance of Epic or Cerner, because they want end-to-end insight into what their patients are doing. So I think about, even where that doesn't occur, it's the effort that matters. So I was with a health system last week. The woman who's the head of their ACO, 35,000 members, they took home about $5 million in MSSP payments last year, so you'd consider them successful. And they talk about being very dogged at the discharge planning station about trying to work with the patient to make sure that they have the right options available and they're not incented or pushed because they have all the freedom of choice, but that the most efficient, clinically appropriate options are available and not biased in another way. So it does take a lot of alignment, and that's why it seems like I'm just looking to get higher rates when I talk about commoditizing the cost of care. And you can use a most favored nation way of driving down to the lowest price and everybody gets that, or you can contract for something where you get, because there are many providers that have the ability to bring information back, proper privacy and security taken care of, but bring that information back. And usually it comes in the way of, hey, we need 5 more visits, and the payer says, I'll give you 3. And that's not really that effective, but instead we could manage a patient much better together.
Great. Thank you, Bruce. We have just 2 minutes left, so I'm going to ask another question. I'm going to skip this one because we didn't see much difference here. So the last question is actually, this is what's called a word cloud, and so we're going to ask this question. Given the discussion you heard this afternoon, what problem do you think home health care is currently not addressing? And so what you need to do is text CareCentrix 392-2233 if you have 333 if you haven't done that already. If you've already done that, you're still connected to the system. So send whatever words you think in terms of what are we not doing today that we really need to address. And the word cloud works that all of the words that you text will show up there, and the size of the text will actually reflect the frequency in terms of the number of responses. So take just a minute. Keep them coming. This is getting more interesting.
It is.
Okay. So just from where I stand all the way across the room, it looks like the biggest single areas are mental health, workforce, behavioral. The size, again, is proportional to the frequency of responses. So things that we didn't even talk really about the home behavioral health gap and the challenges that still poses. So I think it's great that you guys have pointed that out. Our time is at an end. Thank you all so much for your attendance and participation and good questions. And please join me in thanking the panelists for their contributions too.